So I think we're running a little behind, but I liked to group a lot of the medications based on the glycogen storage disease type. So some of them, because when I'm looking at something and it says, if it's a liver, these medications, it's nice to have it broken down as a GSD 1A or, GSD 3. So some of them are grouped together, so I'll try to be efficient, but maybe move on to some other things. Also, previously I've given lectures on surgery and illness plans, which I find are very important. I don't know if I'll get to that, but I do have it at the end. And the key thing with that is, over time, even though you may be, as a physician and as a patient, prepare as well as you can, I find that in spite of your best preparation, there's always someone who wants to screw things up. And so you work hard to do things and you give out these protocols, and sometimes you bring the protocols to the emergency room and the emergency room physician ignores it. And I've actually had times where it's good where the patient and the parent are their best advocates. A lot of times, many of us aren't at a institution that is just specifically for GSD. And so a lot of times, a lot of people travel to Duke or previously also traveled to UConn and some of the bigger centers. I'm probably a smaller center. And so we're always having to educate the residents and such. And I have parents speak up, and actually they do a really good job because I always remember when the patients have IV fluid going on a GSD-1A, and the residents want to shut the drip off, and the parent has to remind them they're going to have a rebound hyperinsulinism. So without saying anything further, I'll go on. So today, primarily these are the objectives, and really I think one of the key things is really knowing the organ systems that your particular GSD affects, and in that way, when you are certain times or whatever, or when medications are being added, you can look at the labels or make sure, check with your pharmacist, is if it really affects the liver, does it affect the muscle, and also knowing which medications are contraindicated, and know which medications, oftentimes it may not affect the liver or specific organ, but it actually may affect absorption of your medications or your cornstarch, and therefore will cause hypoglycemia. So these are the GSDs, and primarily I don't have all the ones that were talked today, up to 15, but I think it's primarily showing that you should break it down into, liver, kidney, and skeletal muscle, because those are the things that can be most important. So one of the things is really you want to check with potential interactions with the pharmacist whenever a new medication is prescribed. A lot of times it can be very difficult. You might have different specialty. I remember reviewing a patient who had lactic acidosis and had a cardiac issue, and the physician was adding lactate ringers on, which was adding into his lactic acid. Those are the type of things that I kind of refer to as, when you work outside your specialty, or patients being seen outside, seeing your metabolic doctor or your geneticist or endocrinologist, to make sure that there aren't things that are going to be added that could be contraindicated. Drugs that can cause hypoglycemia should be avoided. Things like beta blockers can mask hypoglycemia. We see it with diabetes, but also, if you're putting someone on propranolol, that's one of the ones that can mask it. Antidepressants, that can be a big issue, especially with some of my patients. As they've gotten older, I've had a couple patients who have had some psychiatric or psychotic breaks, which then they were being put on some strong medications, which then promote weight gain and other things. And so those can actually affect your blood sugars. It also can affect your liver and those things as well. Insulin and insulin secretagogues, if you have higher blood sugar, if someone wasn't familiar with like GSD 0. You might see a high blood sugar and they have diabetes and give them insulin, or shutting off an insulin drip, or not an insulin drip, a glucose, and having a rebound hyperinsulinism. Growth hormone, that can be a tricky thing as well. A lot of these patients sometimes can have growth failure. And long ago when I was in New Hampshire, if you haven't figured out, I'm not from Minnesota or Missouri. And so, you know, they were put on growth hormone. That can worsen the metabolic situation as well. And then sometimes other things like Tylenol or other medications can affect things too. So due to the consideration should be given to medications at high sodium or potassium, especially in the setting of renal failure. Alcohol, that can predispose patients to hypoglycemia. I do know with our type 1 diabetics, we always have to caution them because alcohol can cause your blood sugars to go high, but it shuts your liver from producing glucose. But also in many GSDs, you're already having the inhibition of being able to produce glucose as well. Also things like lactic acidosis. Those are things that you got to be aware of. In some of the GSD1, where you're developing lactic acidosis, you don't want to give lactate ringers. And estrogen is also known to increase the development of benign and malignant hepatocellular tumors, which some of the GSDs are at risk for. Muscle, those are important things as well. Not all the GSDs. If you have muscle involvement, you also have to know about medications that can affect the muscle. So drugs that can cause myopathy, such as statins and steroids. Succinylcholine can cause rhabdomyolysis, and that's in surgery and anesthesia. So it's important that you check for your drug interactions. I've emphasized this, but I want to emphasize it again, because if you're type 1 GSD1A and you're in surgery, which can cause stress, you know, some of the surgeons like to use lactated ringers. So contraindicated in GSD3A, during surgery, anesthesia, succinylcholine. Again, I'm kind of listing some of these twice. I think it emphasizes the point, but also many of you will be looking at, you know, your own disorder and looking these things up. Propofol can also cause rhabdomyolysis. Hyperlipidemia, statins should not be used as can cause myopathy. And then hypertrophic cardiomyopathy, beta blockers. So, you know, a lot of times with the GSD3A, if you have the heart involved, you may need to be put on some medications, and just be aware propranolol can cause hypoglycemia or mask hypoglycemia. Again, with the muscle issues, I'm just repeating that some of the medications that can cause, like with Mecardals and GSD5 and the GSD7, again, clindamycin can also cause rhabdomyolysis and mitochondrial myopathy, so you should be aware of that as well. Glycogen, GSD0, inability to form glucose due to the lack of glycogen synthase. The liver is not involved or not enlarged and subject to ketones in the treatment's uncooked cornstarch. This is actually how I got into glycogen storage disease initially when I was up in New Hampshire. GSD permissible medications. Avoid medications that can cause hypoglycemia. Avoid medications that can increase motility in the intestine or malabsorption. So, you know, if you think about medications, you know, if you had gastroparesis, people put on erythromycin. So, you know, if someone's going to prescribe your child erythromycin, that can be a factor too. Avoid medications that can cause metabolic derangement. And so these are some of the permissible medications just for people to be aware of. Several of them are antibiotics. And that can vary from some of the GSDs, but I'm just going to list those for time, if that's okay with people. These are permissible vaccinations. This is something a lot of people will ask about as well. Contraindicated medications are things like Augmentin, erythromycin, steroids. They can increase fat breakdown, though sometimes you're going to be put on steroids, but it's just a caution to be aware. Stimulants, because they can suppress the appetite. So oftentimes, if you're being treated for ADD or ADHD, you may need a different type of medication. And glucagon, and a lot of times, we're prescribing glucagon for our type 1 diabetics because if they're low and they don't respond, you give glucagon. A lot of times when the paramedic or someone may come, they may not be aware of that. The child's low and try to give glucagon, which then could worsen the situation. These are contraindicated, can cause, though GSD 0 may not cause as much issue with lactic acid as others. You get the ketotic hypoglycemia and rebound hyperglycemia with lactic acidosis. I think you should be aware of it. Again, some of the other medications, Abilify and Risperidol, which causes a lot of issues with many of my patients. You're already struggling with some of the patients, trying not to gain weight, as was mentioned earlier with the GSD-1s, but if you put some of these patients on Abilify and Risperidol, it can be significant, as well as Ambien. GSD-1A, we've kind of had a long talk about this previously, but I just have that there, so if people had questions or for people who are not familiar. Again, you want to check for interactions with the pharmacist. I think these are kind of lists that you can make when you are going into the hospital. A lot of times, many of you, I don't know where y'all live, but I can tell you there's not as many specialists as we certainly need with glycogen storage disease. So a lot of times, some of my patients who are from Oklahoma, or if they're from, like here in Minnesota or someplace, that not all the emergency rooms or when you get admitted are familiar. So it's always good to have these questions available. Again, some of the review of medications, I'm just going to skip over, but I want to say that I put those there just so when people look up or I don't know if they've had these slides online, you can look through for your own and just be aware of it. Sometimes you also got to remember things like that can cause appetite increase. So like if you're being put on periactin or cyproheptadine, we often use that with patients who are having difficulty gaining weight, and that can stimulate your appetite. And actually, you kind of are trying to be very strict, not strict, but making sure you're taking appropriate calories, not taking excessive. So those are some of the things that you got to be careful about, even with some of these antihistamines. And then be again aware, it's tough because Tylenol can affect the liver, but then also, if you're having kidney involvement, ibuprofen can affect the kidney. But I'd choose ibuprofen initially, but just be aware if you have some kidney issues as well. Just kind of, again, emphasizing some of the medications. GSD-1B, again, it's kind of similar things here as well. Any questions while I'm going through some of these slides? These are some of the medications that are similar. So again, for GSD-1B contraindications, again, things like augmentin, erythromycin, steroids, stimulants. Glucagon, again, because that you won't respond if you're low. GSD-3A is a muscle in a liver, so succinylcholine when you're having surgery. Propofol can cause rhabdomyolysis. It's actually nice if you can make sure, for many of you on the EMR or the electronic medical record, I have some patients who don't have glycogen storage diseases, but they do have a muscle disorder that they're prone to having rhabdomyolysis. So it's often good to make sure that your physician is putting those things on your problem list so that when you go into the hospital emergency room, they're aware, period. Yeah, also, things for hepatitis A, B, and C for these livers should be given to make sure, especially if you have a liver disorder. And again, we're just emphasizing, again, some of this different medications as well. Again, stimulants, we have lots of patients who are on stimulants that suppress their appetite and affects their ability to have normal blood sugars in type 1, but also with other, with a GSD, so you have to be significantly concerned. Bless you. GSD 3B, I don't think we need to do those. Again, if you guys are okay with that. It's good if you ever ask, I can always send some of these slides to you. GSD5 is McArdle's, and it's one of the most common disorders of skeletal muscle, carbohydrate metabolism, and one of the most frequent genetic myopathies. Lack of the muscle glycogen phosphorylase enzyme. Oftentimes there can be exercise intolerance, myalgia, muscle stiffness and contractures, quick fatigue, and elevated CK and myoglobinuria. And there is a severity scale as well for McArdle's. Statins, you should use cautionary in GSD5 and hyperlipidemia. They can unmask or worsen existing myopathy. Succinylcholine should not be used in patients with myopathy as at risk for rhabdomyolysis. Propofol as well, and routine vaccinations can be given in childhood. Again, these are the permissible antibiotics. So Tylenol and GSD5 can protect the kidneys after rhabdomyolysis. You probably wouldn't want to use ibuprofen in this situation. Acyclovir, you should have extreme caution, especially with kidney failure. Some antivirals can cause myopathy. Again, some of the other medications for GSD5. GSD6 is a deficiency in hepatic glycogen phosphorylase, enlarged liver due to buildup of glycogen and elevated ketones and triglycerides when in poor control. You want to avoid medications that can cause hypoglycemia, avoid medications that can cause increased motility, and avoid medications that can cause metabolic derangement. After actually some of the interesting discussions today about fibrosis, it'd be important probably maybe to consider different choices on some of the medications, especially on the liver. Again, some of the antibiotics. These are some of the contraindicated. Again, emphasizing with any hypoglycemia type issue, beta blockers can mask hypoglycemia, so I think it's always something to keep on your mind. And what's nice too, and again, if you contact me, I could just send you your specific one. It doesn't cover all the medications, that's why I tell you to ask. But at least if you have like an index card when you go in, you can have something to ask the physician or the emergency room physicians. It's always good to have on you. Not always that they'll listen to you, but it's always good to have those on you as well. GSD7 is a muscle form, and it's with exercise-induced muscle cramps and weakness. Again, things that affect the muscle. And these are, again, the contraindicated. There's also, and I don't know if I wasn't stopping to read these each, but there are sometimes with these muscle disorders, not only rhabdomyolysis, but malignant hyperthermia. That's when you're giving an anesthesia, and for whatever reason, you start developing, a high body temperature, and that can be deadly. And again, having that on your problem list at your hospital would be very good, and carrying something on you, so if you run into that situation, we can't always do planned admission. Sometimes there's an acute admission for either a trauma or something like that, and having that available would be good. Either index card, or sometimes I have a muscle disorder and have it on your medication bracelet. Here, GSD9, similar to the 3, 6, and 9, and that's that. I know a lot of it was, I could have gone through each individual and re-emphasized, but if you have questions, for the sake of time, wanted to make sure we got through. The other thing is that I'm very big on is the GSD 1 and 3. Now, these are for GSD 1 and 3, but it can apply to your specific glycogen storage disease and can be altered or whatever. I think it's important to have these guidelines because I see too many patients when they do go to the emergency room or they're admitted to the hospital, there's no planning. And I mean, I wish I could only count on my hand the amount of times that a kid goes into for surgery and they don't realize that they need to maintain their IV fluid status. And in spite of getting these prepared and giving it to the pre-op, post-op, there's always been something, you know, I've had a case where they stopped the IV fluids post-op and, you know, you try to connect with the anesthesia, you try to connect with the surgeon, and you connect with them all, but there's always someone who either isn't aware or they tend to stop it. So that's why you always have to be on top of things. You know, with the GSD1, you know, one of the things is platelet aggregation with bleeding time, and that's why sometimes DDAVP is contraindicated. I think DDAVP affects the platelets. I'm thinking out loud. Sorry. So, and these are just some of the things that, you know, for GSD1 that you would be kind of worried about. IV fluids can be interrupted. I've had that happen with many of my patients, even when I've been there and the patient's in the ICU and the parents telling them not to do something. Someone has stopped the IV fluids, which can result in a rebound hyperinsulinism and hypoglycemia. The problem is if you have hyperinsulinism or hypoglycemia with a GSD1 and insulin's on board, you're not only suppressing the ability for any potential glucose to be made, but also preventing ketones, which can also be beneficial in regards to a glucose source. Contraindications with GSD1 surgery, the DDAVP, avoid propofol, beta blockers. In GSD3, you want to avoid succinylcholine. That can cause the rhabdomyolysis, and these are some of the other medications, beta blockers and such. So this is how I do with some of the forms. I don't know how big this shows up. It's Larry Bird, go Celtics. But I used Larry Bert for several years before the championship this year. So, but these kind of go through risks and contraindications, you know, around surgery, around illness, and I kind of place in here. These are things that people can bring with them. Patient cannot tolerate fasting, then they must have continuous IV glucose given to prevent morbidity and mortality associated with hypoglycemia. Monitor the glucoses pretty frequently. I like to have 2 functioning IVs because there's always one IV that pops out, so at least you'll have 2 in case there's an interruption of glucose. And then I'd like to have them for prior to surgery to be admitted like 24 hours prior to surgery so we can monitor their fasting and have them in good glucose control. And that's actually very important, you know, for like GSD1 because, you know, oftentimes being in good control, it will help the platelets function better and things function better metabolically. The other thing, stress of surgery can cause lactic acidosis and hyperglycemia, and you might need to lower the glucose. And sometimes, too, if you give too much glucose, you can cause a lactic acidosis as well. And the stress of surgery. So a lot of times you could be having normal numbers or, you know, slightly high, but the stress of surgery can cause lactic acidosis in itself. So you need to be having them monitor glucoses and lactic acidosis as well. And this is kind of a list of contraindicated medications. As I said here, DDAVP is contraindicated. And having these things available before the surgery and when you're at the surgery or when you go to the hospital is extremely important. And so this kind of gives some of those things as well. And it talks about how to wean on these. I can't, these are small lettering, but I see better without my glasses on, but my son doesn't understand why, but it's an age thing. But So these kind of go on how to wean off, how to go back to a normal meal plan, watching and, not weaning too fast. And these kind of give some of the how to fast to wean and some of those other things as well. This is for GSD1 and the rates. And then understanding the potential complications, developing a protocol for illness for both GSD1 and GSD3. And having oftentimes we would have a protocol set for the emergency room if they do come in. But if they don't have it, you can always have the parent could have it or bring it in or have one available or copies. And advocating for your child, I'll tell you, sometimes I've had parents come in and I don't mind because I know they've done an excellent job, but some of the docs, because a lot of times, and I don't know if you found this, but a lot of the docs don't like to be challenged. They don't like people telling them how they should manage. But it's actually interesting because I know, the chatter sometimes with a couple of my patients, they're like, oh, that mother's very difficult to work with. And I'm like, I'd rather have her working on her child than you. Also, I'd rather have them advocating because I know they'll prevent a problem from occurring. And that's probably one of the more important things as well. So, and these are some of the things, you want to prevent some, serious metabolic decompensation. These are some of the things with the drinks and the emergency protocol. Then we have Larry Bert again. He's got GSD1 and GSD3. But for these also, it's just specific to that disease, some of the things that you need in regards to IVs, some of the things to be aware of, not stopping the IV glucose. And that's it. Sorry, I kind of rushed through it, but I hope I made the point. I think it's very important to advocate for your child. Many places where you go, if you're traveling and such, may not be familiar with the GSD. A lot of my patients, I have a patient who would get admitted down in St. Francis in Tulsa, and they would just call me up because not many people are familiar with management. But I think that's extremely important because, when you go to a lot of the rural areas or even I'm going to tell you, even academic centers, they don't have a great program. I mean, it's really nice. Duke does a fantastic job. UConn does a fantastic job. I know Cleveland, but then there's oftentimes 3 or 4 hours between some centers. And so it's really nice when you can be prepared. And preparation is the best thing for all. So any questions or anything? Did I go too fast? Oh, I can't. There's a hand. The light's in my eyes, but I can see. Mm-hmm.
My son has that. I do have some concerns because one of the problems, which is what parents that sort of like pass through the diagnosis, is real-life labor, which doesn't seem to be one of the things associated with crime. And so I'm kind of caught up in a situation of, did we get a misdiagnosis of the type, or what could explain real-life labor with the type 9? And also, I think you brushed through the slide that talked about your medication for number 9. So if you don't mind going back to that slide, I would like to have a look at that.
I go by it. Oh, there's another slide, I think. Oh, the end. Thank you.
I was wondering about like the electronic prescription systems. I know a lot of them have alerts that come up automatically about contraindications. Are those in place for GSD?
I would suspect not. A lot of the electronic records usually come up in regards to my experience is more about between the medications themselves, you know. So I don't know, at least on mine, we have Cerner where I'm at, so I don't know if anyone has Epic or does yours? Go ahead.
So I would not anticipate somebody has an alert system for GSD, like you can only build one in one institution. But much as you covered that, I would recommend putting these medications on an allergy list.
Yeah.
Especially a lot of the hospitals now talk across. And so, for example, if you have lactated rigors on your allergy list and somebody tries to order it, most of these electronic systems now will do an alert for that. So I would have to feed it with information. And so as a parent, I would put this with the medications he's not recommending as allergies, like you would on lactated rigors. I think that has a lot of its.
That's actually an excellent point because, you know, especially for some of the muscles, if you go to anesthesia, something could have succinylcholine on the allergy list or glucagon for a lot of the GSDs where it won't be responsive. But that's probably the best place. I think I see someone back there.
I just had two quick questions about, my mind goes to practical because my daughter always gets sick in the middle of the night. And thankfully, we have our doctor's cell phone number, but there's always like a panic place I go into whenever there's a new med. So I was wondering, it seemed like for a lot of the types, there are some specific medications that are specific to types, but there's a lot of really like overlap between your slides. So I didn't know if there was just a centralized table, like a document with the table and the types and what to avoid.
I don't believe we have a centralized table. I mean, that'd probably be an excellent suggestion. I can tell you, I got a lot of these from just kind of talking to people. I think Iris Furicchia from UConn. I think I got some from Duke as well. You know, but it was kind of more talking to different people. And that's kind of why I know it doesn't make sense, but I kind of put this so that each one had its own table. But I'm also willing to share, but it's probably a nice little project that would be good for the AGSD to have and be agreed upon. But you never should suggest a project because then you get in charge of it.
I would be happy to do that project if you want to give me
No,
your...
I'm talking about myself.
Yeah, that'd be great. And then my other question was just, we have our own medical letter that we've used when we've traveled, but yours was more extensive and lessons hard learned by a lot of patients. So I don't know if there's a way to get your letter. So
Just email me, I'll send it to you. And you might want to check because, you know, sometimes there's some subtleties among the GSD docs. And so, you know, I think this is pretty general, but, you know, it's always good to check with your doc and see, you know, what they want to scavenge.
Thank you.
Just email, I don't know if my email's around there. Oh, yeah, there it is. And I'm there, well, I'm here for the next 3 months and leaving University of Missouri at that time. But if you get a hold of me, I should still have that number. Okay. Yeah, or whatever. That's fine. Yeah. I think this is going to still be functional, though.
Hi, I am from Wisconsin, and most of our rescues and even some of our hospitals around us do not carry D10. So they are always converting everything, and I don't like that. I don't know if what formulas they're using are correct. And I guess for me, it's a matter of like, is there any list that, or somewhere that I can go to make sure what they're using is actually what they should be using? Like the right amount of, I don't know,
Glucose.
saline to the dextrose.
There are, conversion things on, how many milligrams per kilo per minute at certain ages. I think that might be on the GSD 1. I don't know what your child or you may have.
We're a 1B.
1B. That's unusual. I'm not familiar where someone hasn't had D10 available. So-
I have thought, like, now have rescue around us that carries D10, and I don't understand it either because a lot of them do.
That's pretty common, because dextrose has a short, D10 has a short half-life, a short shelf life. It's about 18 hours. So unless it's going to immediately spike and be used, most smaller pharmacies can't afford to keep it there. Your big academic center, there's always a constant infusion of it going through. But the smaller rural places tend to not have that. Now, one of the things at the hospital I was at, I actually worked with the pharmacy there, because you can actually get the extra dextrose to turn D5 into D10 that the nurses can spike in the middle of the night. But that will take some work on your part, is that you have to eat or you tend to go for a while.
Yeah, so I guess I just want to know that what they're using is the right conversion, because I don't know. I'm not.
There's a rate in your letter. D5 should be twice the rate of what your D10 in your letter is.
Right.
I was wondering though, also sometimes if you're trying to limit your rate, then you're kind of like, how they would increase the concentration because they can't suck.
Yeah, that's where you have to have a pharmacist come in and physically mix that up.
Yeah. But then the problem is there's no pharmacist in the middle of the night. Do they carry D50, vials?
So that's the thing, is like they're carrying different things all the time, and so I don't know all the time. That I almost need like some kind of list where I can know what I'm converting over at that point.
You, is that Dr. Ryan? I don't know. Oh, okay. Yeah, I thought it was you. They got lights I can't see. Blinding. But do you have a conversion thing on the D10 or something, or D5s?
They're out there. I mean, it's the rate. There's a national shortage of like the D10, the AMPs and D50. So even for rescue type of stuff. So a lot of times the pharmacies are having pre-mixed D25 per se, and everyone can limit the rate. But then it's just a mathematical calculation. It's, D25 is 1.5 times, it's 2.5 times what D10 is. So it's all just a fractionated.
Yeah. No, I'll see what I can find too, if you just email me or whatever. But Dr. Ryan, I'm glad you spoke up there. Oh, Dr. Woolman.
Add that I really do agree that ultimately to get the correct fluid, it does need to be a pharmacist. But I would highlight in that emergency situation, and Dr. I love that I have certainly used kind of, so it's twice the rate. So whatever your D10 rate is, what D10 is 10 grams per 100 mLs, and D5 is 5 grams per 100 mLs, like all of us think in grams. So in those emergency situations, when you're coming in the middle of the night, somebody gives you
Are there any other questions?
Okay, well, thank you so much. Ladies and gentlemen, just want to give a round of applause to Dr. Bachrach here. Thank you so
Thank you.
much. Thank you so much. This is obviously a subject matter with lots of questions, a lot of concerned parents here, and with all of your guidelines and help, it's definitely such a big help. So let's give another round of applause, ladies and gentlemen.
Thank you very much. It's always an honor to talk to you.
Guess what? It is photo time. Who's ready to take the annual GSD photo?